Our next session is titled, How Will Brain Tumor Treatments Affect My Brain? Brain tumors and their treatments can affect brain function. And by understanding the basic principles of brain function and the relationships between tumor location and treatment, you can better prepare for and manage any potential cognitive changes. We're very lucky today to have Dr. Shawn Hervey-Jumper, professor of neurosurgery at the University of California, San Francisco, who is here to present on this topic. Dr. Hervey-Jumper is a neurosurgeon researcher with a clinical practice focused on the surgical management of patients with brain cancer within functional areas using physiological mapping, and he will be elaborating on this. In his research laboratory, he seeks to understand how brain tumor cells influence functional circuits and cognition. His ultimate goal is to better understand the mechanisms of cognitive impairment, thereby leading to novel treatment options focused on improvement of brain network recovery, and therefore better cognitive outcomes for patients. Thank you so much, Shawn, for joining us today, and we look forward to your presentation.
Thank you so much for having me. Can you hear me okay?
Yes.
Great. Okay. I'm so honored to be here. I've always learned so much from you, Dr. Castro, and Dr. Logan, and that last session was amazing. Thank you to ABTA family for welcoming me back. And thank you to the patients, families, and caregivers that are spending time on your precious Saturday morning to talk with us. So again, I'm Shawn Hervey-Jumper, and I'm a clinically active neurosurgeon, and my lab sits at the intersection of systems neuroscience and cancer biology. And I'm tasked with this idea of helping us talk through how brain tumors and brain tumor treatments affect our brain. And these are my disclosures and funding sources. And funding sources are relevant to this talk, but no other disclosures to think about. So how we structure the next few minutes together? Well, I think it's probably best if we start with a general overview about just what we know about how our brains work. We'll talk about how brain tumor characteristics and different brain tumor subtypes may differentially impact brain function. We'll talk about how brain tumor treatments impact brain function. And then you have to talk about some strategies or even concepts for cognitive and neurologic function recovery, as well as quality of life, building on what Dr. Logan spoke about in her excellent presentation. So first section, what do we know about how our brains work? And this is a great image I just wanted to put up to put some context in here. Our brain is really made up, we think, of about a little over a billion nerve cells. And these are arranged in patterns, and they're coordinated in patterns, and they help us coordinate emotion, behavior, movement, sensations, all the things that we need our brains to do. So it's a complicated highway system. We call that highway system a neural network. And this is a network of nerves and neurons that really communicate, and allow our brain to communicate with the rest of the body. And this occurs in milliseconds, right? Just think about how fast we pull our hand away when we touch a hot stove, right? We don't have to think about it. This happens in milliseconds. So while all the parts of the brain work together, each part is responsible for a specific function. And that function is made up of individual brain cells. You can see everything from complicated structure of Purkinje cells there to pyramidal neurons that are in the movement or motor cortex. And in the center of the screen here, you see this structure called a synapse. And that's where the nerve cells communicate. Turns out these nerve cells don't just communicate with nerve cell to nerve cell, but nerve cell to other types of cells in the body as well. But it's this communication between nerve cells at a synapse where chemicals are released from one neuron to another. And it's the strength and the efficiency of those communications that really impacts everything we do and all the way that we interact with the outside world. So if we take a step back here, what does this mean for cognition? Well, cognition is a complex thing, as Dr. Logan was talking about. Cognitive processing requires cellular level, kind of those neuron to neuron communications, as well as neurons to these helper cells called glial cells. We know that they have to work both locally in what we call local synaptic connections, and in a broad range, we call those distributive cognitive networks, like throughout the brain. We know that throughout life, there are processes. I'm going to use the term here. It's called adaptive neuroplasticity. That means that there are cells in the brain that help those synapses become stronger or weaker or modulate how well or efficient those synapses function. And this happens by way of certain types of cells called progenitor cells or NPCs or neuroprogenitor cells. You don't need to know the names of these, but there are certain parts of the brain that makes these cells, particularly in the hippocampus, and they help all of the efficiency of this connection of the superhighway work and become stronger or less strong, depending upon what we need. Here's a general overview of what we think about how brain tumors affect and alter healthy brain. We can see here, then again, there are various models or theories about how we think that brain tumors affect networks or important areas of the brain. To the left, you can see the little gray tumor, and the pink area is that you just use, for example, areas of language for language function. There's one model in which we think that brain tumor cells invade, or actually, literally, the cells come into the functional areas and they kind of destroy the neurons that are there. There's another theory in which it's called a compression model, in which it's not just that the brain tumor cells come in and break up or destroy cells, but they push on the structures so that the nerves and the axons or the nerve fibers don't work as efficiently just because of pressure on them. There's a swelling theory in which the brain tumor itself causes swelling or edema in the brain, and that edema or swelling makes the normal brain cells not work as well. There's the vascular steel idea, where we have blood vessels that are in the brain, and in those blood vessels that are in the brain, we can see that the brain tumor itself steals some of those blood vessels. So the blood supply to the normal brain becomes less efficient. It can cause tumor-associated strokes, but even if we don't even see strokes, we know that some of the blood supply is lost, and those neurons are a little stressed out because they have less blood supply. There's a modified theory of this, which we'll go into in a little more detail, which is called circuit reorganization, which basically means that the brain tumor itself actually borrows from neurons in the other parts of the brain, and the nerve cells that make us able to speak, communicate, and do all the things that our brains normally do also drive the growth of our brain tumor cells and boost the activity and the efficiency that the tumor itself can grow. So we know that, again, some healthy cells are destroyed, while other healthy cells in the brain are actually just altered or remodeled. Um, and all of this impacts the efficiency or how our brains communicate and function, and therefore resulting in changes in cognition and behavior. So brain tumors can change structure and function. Okay, and let's talk about what that means. And we're going to take a glioma view to this. While I would say that many of the things that we'll talk about the next few minutes also apply to other types of brain tumors, meaning brain metastasis, and maybe to some extent even meningiomas, although that's less worked out. We know that there's several different types or subtypes of gliomas in the brain, and these are the types of treatments in the grade 2, 3, and 4 gliomas that we think about. We know that brain tumors themselves, as we described, affect the brain in a couple of different ways, both locally, within the same hemisphere, but distant, and even in the opposite side of the brain. And it's summarized in this way, as I mentioned. Nerve cells can become more inflamed. There are inflammatory, what we call cytokines, or inflammatory markers that are boosted or elevated both by the tumor and the treatment. There are these important cells that we need to regenerate the brain that become less active both by the tumor and the tumor treatments, like chemotherapy and radiation. They're critically helpful, but they make these cells not work as well. There's the diminished number of the types of mature cells, and maybe not even the progenitor cells or the cells that help replenish the brain, but the mature cells that are just doing their job. Those need to be repleted as well because they become diminished. And we know the superhighway in the brain, we call these white matter pathways, they become less efficient over time, and there's loss of the connectivity, or how one part of the brain would connect and communicate with the other part of the brain, as something called functional connectivity. There's a couple ways of thinking about this, and while Dr. Logan was talking, I could not help but pull up a book that I have in my office because it's somebody who really likes history. I have a book that I read often, and it's written by a brilliant anatomist and surgeon, actually from Canada. His name is Wilder Penfield, and he wrote this kind of about his life's work in the early 1900s to the 1950s. And what he described was this debate from the mid 1800s to the 1900s about how the brain worked. And there was quite a bit of a debate. There was some who thought that the whole brain was responsible for all functions. And there are others that thought that what we call the localizationist view, meaning one part of the brain is responsible for one thing and another part of the brain is responsible for another. And interestingly, the very first real causal evidence for that the localizationists were going to win was through somebody called Broca. Anyone who knows or thinks about aphasia knows that there's a brain area named after this person. His name is Pierre-Paul Broca. He was French and a brilliant anatomist, also a general surgeon. And he had a patient he treated. His name was Leborn. And interesting, Leborn was born met Broca in his 50s. And this is a gentleman who, over a 10-year period, had an inability to speak, and progressively, over a 10-year period, became more and more paralyzed or weak in the opposite side of his brain. When Broca did an autopsy, they found a cyst or mass in the left side of his brain in an area called the third convolution. That's now been known to be called Broca's speech area. But the important part, and the reason I bring this up is twofold. One is many of us believe that this first patient, this first person that really proved that the left side of the brain and the frontal lobe, the third convolution of the brain, is the area that's responsible for speech. This probably was a patient with a brain tumor. And what makes this even more interesting is the fact that in the body of work over about 100-year period after that, the models or the theories that we have to help us understand speech processing, similar to what Dr. Logan said, intentionally exclude patients with brain tumors. And they make a point to say, because, well, brain tumors disorganize the brain and it's impossible to understand brain tumors because it's just so disorganized. Well, strokes are easier to understand. And so we think that aphasia or how speech is processed is really based on stroke models for people who have had strokes to understand the brain. Well, not so much with people with brain tumors. We shouldn't study that. That brings us to this slide here and why I put this up. What we have here is measuring the electricity of the brain and the surface of the brain of a patient who has a brain tumor. And what you see is that these bright orange and red colors are electrodes or areas of the brain that have increased electricity, meaning areas of brain tumors that actually have electricity that's transmitting within them. Meaning that the brain tumor itself, in many settings, can be a functionally active, electrically active area of brain. Why do we care about that? And why are we talking about that now? Well, we'll talk about that now because if we just put the surface of the brain on the screen, as we can see on the left side, it's really hard to tell, like, this is a glioma, where the tumor ends and begins, right? For those of us who stare a lot at brains, in my day job of removing brain tumors when it's appropriate, I can tell you that there's a slight widening of cortex where the brain tumor is, and there's a little more narrow towards the bottom where the tumors begins to disappear. But you can visualize and see that some types of brain tumors are actually parts of the brain themselves. So it's no surprise that brain tumors cause impairments, and brain tumor treatments can also cause impairments because you're actually affecting the brain cells themselves. In the middle slide, we can see something something called a task response, similar to the last slide, where the person is saying a word in this example, and we can measure the electrical activity both within the tumor in red and within the normal appearing areas in blue. And you can see in both of them, you see the normal pattern that you should see when a person begins to speak, meaning everything that you see from normal brain, you see in a tumor. But then why do people have impairments like Dr. Logan was talking about? Well, it turns out if we look at the right side of the screen, this is something called an entropy measure. All that means is that you can measure the amount of information that's living in the cortex that is housed or controlled in a cortical area. Won't go through how we do that, but it's called a information theory or measuring information content uh, assay. And you can see here that if you look at the blue areas where the normal regions of brain and the red areas, which are the tumor regions of brain, you can distinctly see that the entropy or the amount of information stored in the same area of brain is less for tumor cortex relative to normal appearing cortex. So a lot of the ways that we think brain tumors cause impairments is not because they're dead areas of brain, but because the information that's stored is in a less efficient manner. And because of that lack of efficiency, it makes tasks harder to complete, and it makes impairments more likely. And therefore, patients start to feel and change. They feel that their experience with the world changes. But it's all born again. There's a relative lack of information, all born of this idea early on in the 1800s to 1950s that brain cancer itself is probably not a relevant model. And just recently have many investigators, including my lab, started to think about these processes and study them in people and people with brain tumors. So brain tumors change brain function. Let's talk about this a little bit. And should say brain tumor treatments. So let's think about this a little bit. There are a number of different types of brain tumor treatments. One type of brain tumor treatment is surgery, right? Another type is chemotherapy. Another type is radiation, targeted molecular therapies. We'll go through some of those. Let's start with the surgery context. And what you're seeing here is why we do surgery, particularly for patients with low and high grade gliomas. This to the screen left is called a recursive partitioning analysis. You don't need to know what that word means, but all we need to think about is that this is a statistical model where you take a bunch of variables and you plug them into an algorithm to try to classify which of the variables are most prognostic or most significant on the overall outcome, in this case being survival, and how these variables interact with each other. And you get these web tree type formations. And each of the nodes of the square boxes tells us a variable that's of particular importance. Turns out for patients with diffuse gliomas, low-grade gliomas, how much tumor is removed, how big a tumor is at the beginning, and the subtype of tumor, meaning whether you have an astrocytoma or an oligodendroglioma, are the main drivers of outcome. Plus whether you use the chemotherapy or not. And as a matter of fact, these drivers of outcome, you can map those onto something called a Kaplan-Meier survival curve. Again, all this tells us is that if you look far to the right in years and you draw a line from the 50% mark, you can see group 1, group 2, and group 3 in terms of overall survival. What's important is that the amount of tumor that's removed or the greater amount of tumor that's removed and the smaller amount of tumor to begin with are two of the major drivers for outcome for patients with diffuse gliomas, diffuse low-grade gliomas. Well, we can't really control the size of our tumors to begin with, but we control how much tumor is removed in some circumstances. So that brings us to this point. If we think about how much tumor is removed, well, what's the benefit? What's the time it's the minimum amount you want to remove? Well, it turns out about 75% of tumor removal is where the benefit begins. And every bit of that, more greater, offers a benefit to patients. And I'm going to get to why I say this in the context of this talk in a moment. If we look at the Kaplan-Meier curve here in the center, you can see that if we talk about 100% of the tumor removed, that's the yellowish curve. If we talk about less than that, that's the orange curve. We call that a GTR minus, don't care about the terms. Or we say more than 100% of the tumor removed, that's the darkest curve, the brownish one, reddish brown. We can see that outcomes or survival outcomes are greatest even when you remove outside of the imaging defined tumor margins. right? More is better removal. But here's the point, and why bring this to light right now. These sort of measures in the last slide are independent of whether we have permanent neurologic impairments. So, for example, we look at the left side of the screen. Take the same approach for patients with glioblastoma or malignant disease. We can see that if we factor in permanent neurologic impairments by our treatments, that a new permanent impairment actually drives the outcome, the survival outcomes for patients, not so much or not as much as the extensive resection. So the goal is to remove as much of the tumor as we can without causing permanent neurologic impairments, particularly motor impairments for patients. We know that thankfully in the setting of IDH mutant low-grade patients, in the vast majority of patients, roughly just over 90%, are able to return to work. This is measured between 6 months and a year. We also know, and this is the right side of the screen here, that impairments fluctuate, meaning our brains are incredibly plastic and reorganize and get better. So if we look at the top here, that's something called the speech fluency or just overall speech scores. And we look at these blue bars. Blue bar 1 is before surgery. Then we have a measure 2 days after surgery. And then we have a measure at about 1 month after surgery. We can see here that the blue bar prior to surgery for most patients is pretty good. Speech function is good. If for left dominant left temporal tumors, 2 days after surgery, we expect that function to be worse, right? We expect with swelling and all the effects of surgery, everything to get worse. And then we expect it to get better. You see this kind of V-shaped formation where within about a month, really 6 to 8 weeks, we expect people, not everybody gets back perfectly to their baseline, but most people get back and recover. And the question is always, those folks who don't have organic, spontaneous recovery, what can we do to help them? And let's talk about that. Let's talk about what that looks like. So here we can see, and we should also see how this happens. So this is a beautiful study that I really like. This was led by, it's the work of Feroz Tarapur and Sri Nagajar, and our two brilliant colleagues. And their goal was to understand how language, and again, I'm just using language as an example, but how language is reorganized and recovers in patients longitudinally throughout their disease. So in this sort of idea or mapping out or understanding this recovery process has significant implications on the prevention of function loss, both as a result of treatment and the result of tumor growth. They used the whole brain activity approach, something called magnetic encephalography. That's where basically you measure the activity of neurons in the brain while people are saying words and completing sentences. And they measure the activity in the brain of roughly 75 people at 2 points, at diagnosis and then at the point of recurrence. And what we see here, what this slide is showing us, is what something they call the laterality index, where they look at the hemisphere of the brain that was active at the point of diagnosis, and then they use the same measure to understand what happens to the hemisphere of the brain at the point of recurrence. You can see as patients underwent a second MEG or a second brain activity scan, they were shocked to see that the area of brain that's active at recurrence changed hemispheres, or we call shift laterality, as you can see in the gray box, in roughly 30% of patients. This change was both from left to right or right to left and bilateral. Turned out that roughly 23-25% of patients, it was a switch from left to right side, left hemisphere to right hemisphere, where it was, or left hemisphere to both hemispheres of the brain, while there was a complete switch where you're just only left hemisphere dominant to only right hemisphere dominant in roughly 5% of patients. That's pretty shocking. And to think about, and not something that we don't take account for as much, that we need to start thinking about clinically for our patients. What happens with radiation, or what do we know about radiation? So we know that radiation, of the many things that it does to kill brain tumor cells, and it's very effective at that, and one of the best treatments that we have for patients, we also know that it hurts some of the brain tumor cells, not permanently, but it does at least temporarily. And it's important to remember that the cognitive trajectories or the speech trajectories, using this as an example, change. So it turns out that when you give radiation, some of the progenitor cells, we call those NPCs or neural precursor cells, are stunned or just less active during and following radiation, and they have to recover. If you can see here again, look at these blue to green boxes in the upper screen here. We can see that if we just take a look at initial scores, again, we're just using speech as an example, and each of these solid lines represents different aspect of speech: picture naming, text reading, auditory naming, hearing an auditory cue and giving a verbal response back, saying sentences like syntax formation. We can see the trajectory and how people are doing, or how well they're doing or not doing throughout the trajectory. And we can see here during the initial period at diagnosis, scores are pretty high, close to this 4 number. Immediately following surgery, we know they drop. Then you have that recovery period at about 1 month following surgery, up to 3 months. For most people, but within that 1 month to 3 month period, they're receiving radiation. And during the early periods of radiation, many of my patients will say, and this matches with this trajectory, that their cognition, speech, their function is pretty good. And then following radiation, there's a decline. Look at this post-radiation decline that we see. And then after that radiation recovery period, we see that start to get better again by the 12-month mark. And I put this up here to say, again, this is organic, spontaneous recovery because we don't yet have really good ways of stimulating or promoting this brain recovery that are reliable or that are standard of care. Not yet. But this hopefully helps us understand or really appreciate that we have to give ourselves a little bit of grace and patience, because symptoms will change. They will fluctuate throughout the course of disease, and throughout the treatment course. That's really normal and expected. So, what are some strategies? We talked about a lot of the natural history or some of the natural history. What are some of the strategies that we can think about to improve recovery? So, let's just follow this here. Um, and I want to use a definition here, and I'm going to use this definition called central nervous system plasticity. There are many definitions of plasticity, but I just want to call it this: the ability of the brain to undergo a structural and a functional change in response to any new experience or condition. Frankly speaking, our brains are quite plastic, right? If we go out and experience the world, most of us will probably learn something new today, have a new experience, and our brain therefore has to recover or modulate or change in response to that. That is exaggerated when it's talking about receiving tumor treatments. So, what does this mean? How can we think about this? Well, there are a number of emerging treatments, and I'm just using these not as standard of care treatments, because they're far from it, the next couple of slides, but I think they're going to help us understand where the field is going and the type of opportunities we should think about as patients and families in the next few years to come. So this is a slide that I was really excited to read, and for a study I was really excited to read by a couple of our European colleagues. This is Sandro Krieg's paper, focused on transcranial magnetic stimulation. That's a mouthful, called TMS. This is an approach which is increasingly applied to identify functional areas of brain by delivering a small amount of electricity. And measuring measuring basically how neurons talk to each other. It's non-invasive. As a matter of fact, there are stimulation protocols, meaning you can apply this type of extracranial electricity or currents to the brain in stroke and depression to try to improve outcomes. This was the first paper that was a clinical trial for a series of patients in which this was applied for patients with glioma but patients with glioma who had recently experienced a stroke um, from their glioma or glioma surgery. So you can see here the treatment history in these black line, surgery for brain tumor resection. A postoperative MRI shows eligibility criteria, meaning somebody who, as a result of their surgery, had a stroke within or around the resection cavity. There's a we call a motor mapping. This is where you apply TMS to look at the brain activity to make sure the motor pathway is intact and relevant to stimulate. Then you measure functional behavioral outcomes, meaning their motor responses. Then they applied this, what we call repetitive TMS. This is the protocol, 15 minutes, 900 pulses, combined with really aggressive targeted physical therapy, and measured the outcomes for patients, both immediately after the stimulation and the hospital stay, as well as the 3-month follow-up. Here we can see the black line, I'm sorry, the red line are sham treated, meaning these are people who were part of the study that did not receive the stimulation. Where at the 3-month follow-up period, you can see the folks who received the stimulation had better motor responses. That's the FMA score point relative to those who received the kind of the placebo kind of fake procedure. This was really exciting to see. It's hard to distinguish how much truly of this is the effect of having really good targeted physical therapy versus having the stimulation. But these sort of approaches, I think, represent the future, and there will be more and more validation of this type of work in the next few years to come. What else is on the horizon? So we talked about these cells called neural precursor cells, and um, these are, again, these really important cells in the brain that are responsible for making sure the brain recovers or regenerates. It turns out that tumor treatments and tumors themselves have a propensity to change those precursor cells, decrease the number and decrease the way they talk to each other. In this group, Aaron Gibson and another wonderful group of investigators, they wanted to understand whether pharmacological stimulation of these precursor cells can promote cognitive and functional or brain recovery in any way. And they focused on one particular drug called metformin because of its preclinical effect. It's known to have the ability to help recovery of those precursor cells for a couple of mechanistic reasons. So in parallel, they ran a rat study or a rodent study and a human study following radiation injury, radiation treatment. So in the rodent model, they found that the metformin increased or enhanced the recovery of the precursor cells within that area of the brain called the hippocampus. That's where those little blue blobs are, because it's so important for memory, specifically an area called the dentate gyrus within the hippocampus. They subsequently ran a 24 patient, 12-week pilot study for patients. And this is a really well controlled study. It's something called the placebo controlled crossover study, in which patients did and did not receive the drug over a 12-week period. And they have a placebo arm as well, as I mentioned, and they found no safety problems, right? So this drug was safe and there were no serious side effects. But the team found that metformin was associated with a better performance than the placebo in working memory for those patients. Now, again, this was a pilot study, it's early phase. Um, this is just focused on working memory, but this sort of work is helping advance what the dose might be for this sort of study, as other groups are thinking about how to expand this and think about whether metformin and other types of treatment should be part of standard of care, or at least be considered. More on the horizon for this sort of work. Okay, we just received a brilliant talk by Dr. Logan, focused on cognitive rehabilitation, and I am not going to begin to address what she's already done. She did a great job, but I will say this: cognitive rehabilitation is effective, and it's used for patients with diffuse gliomas. There are gaps in cognition, and these need to be addressed. And having dedicated specialists is critical. There are many national experts in this space. Dr. Logan is one, Chris Wire-Jamora. There are many around the country, or several, I should say, around the country. Much of this work can be by televisit. There are a number of questions that remain in the field in terms of how to effectively screen. What is the best screening tool? Dr. Logan kind of alluded to that a little bit. There are a number of tools that are being validated. How to manage comorbidities for patients in light of these cognitive impairments and cognitive rehabilitation. How to talk to your doctor about these sort of things. What's the optimal timing of treatment? That remains unknown in an area of active investigation. And what's the best cognitive rehabilitation program? Again, Dr. Logan mentioned actually a couple of excellent programs that are being either designed for or adapted for patients with brain tumors. And I have no doubt that this will be expanded. This idea of environmental interactions and strategies, and as a measure, as a way of, as one approach for cognitive rehabilitation, is really important. Again, I don't want to go into this as a not a neuropsychologist. I just couldn't help but put a slide up here to make sure we understand how important these sort of therapies are. We've had a fair amount of talk on exercise already, so I'll kind of gloss over this, particularly in light of one of our next talks is really focused on exercise, which is excellent. This is one approach. This is Karen Gehring, and others have focused on a couple of trials that have been published now, pilot studies showing the improvement in cognitive performance and quality of life measures with exercise, how much exercise and when and what type of protocols. That's really hard. It's a really hard question. I know that there are an increasing number of patient groups or patients themselves that are putting online on Facebook and Twitter and other places their personal exercise regimen that have worked for them, because there is a dearth or a lack of literature about what type of exercise regimen is best for patients. And so again, these are important strategies that we have to think about moving forward, and lots of work. And I think we'll hear more about this in a moment. I'm going to stop there because I think I may actually be a couple of minutes over. And I want to thank you, the ABTA community, and all of our patients and families, and want to make sure we have plenty of time to answer any questions that you may have.
Thank you so much, Dr. Hervey-Jumper, for a terrific discussion of the effects of brain tumors and brain tumor treatments on cognition and brain function. It was wonderful to see you review all those studies and all the things that we have learned from those studies, many of which you have done yourself. And it's a real treat to have you here today to answer a few questions. So we have a question that asks, why do survivors have similar side effects post-resection, and removing a tumor doesn't eliminate what survivors experienced prior to surgery? So, a patient presents with aphasia as the presenting symptom of what's eventually going to be diagnosed as a brain tumor, and subsequently they have their maximal safe resection, and there might be residual aphasia. I think you elaborated a little bit on this, but maybe we can revisit that.
Yeah, thank you for that great question. Not just residual symptoms. Symptoms could be worse, or often worse, especially immediately after surgery, and then we would expect that to improve and recover. It's this. One of the early slides I pointed out was really kind of debunking this idea that brain tumors are just compressive lesions, right? We used to think of brain tumors as, well, it's outside of the brain, it's just pushing on things. And therefore, if it's just pushing on things, if we can relieve the pressure, symptoms will get better. Turns out that's true in about 50% of the time. There are patients that get better. I have a couple of patients just this week that came back on their aphasia, for example, is so much better than prior to than their initial diagnosis. But there are many who are not. And a lot of that, we think, is about this remodeling idea, which is that the brain tumor itself has kind of eroded into or invaded or pulling an activity from those functional areas. And what seems to happen is that sometimes we have brilliant brains that are recovering and have a great capacity to recover, but sometimes the speed or pace at which the tumor grows outpaces those recovery mechanisms that are already built and baked in to our brains. And that's where, and why I wanted to just at least briefly chat about some of these emerging techniques, technologies, and research that may help speed up brain recovery so that we can get to a better max or more complete recovery faster while we're receiving our brain tumor treatments. I hope that answers the question a little bit.
Thank you. Yes, for elaborating on that point. And there was a similar question on that regard. Does healing tissue or scarring contribute to side effects post-treatment, and does this improve with time? And there could be surgical scarring and scarring from radiation as well.
Yeah, that's right. That's why I really like I show that symptom trajectory over 18 months slide quite a bit to patients to remind us, yes, there is recovery. But remember, for many patients, especially with malignant disease, we can't necessarily wait for full recovery, full cognitive recovery. So the second you're recovered, we're already talking about the next stages in treatment because we're watching on imaging the tumor start to grow back. And so you get this kind of up and down and up and down, this fluctuating cognitive course for many patients, which is really hard to experience for patients and families. I know we have a lot of work to do to make this process better.
Thank you. There's a very interesting question about chemical stimulants and their effect on cognition. So is there a belief that a chemical stimulant other than metformin, which not necessarily a stimulant, but the patient is also mentioning caffeine and nicotine, help maintain or increase cognitive function post-radiation? If so, is there evidence that such stimulants have an impact on malignant cells proliferating? For those already using nicotine replacement as a way to try to have smoking cessation pre-diagnosis, is there any real reason to stop?
Yeah, so man, okay, whoever asked that question has read some literature and understands a little bit how complex this is. That's a really good question. So, all right. Over the last, I'd say 8 years or so, we've increasingly now understood that activity of neurons can actually make cancer cells grow. We also know that stimulants make neurons more active, and more activity in the brain is also, we think, more activity in the right places at the right time can really enhance cognitive recovery. So this question is getting at this intersection of, can we pharmacologically give things that make the brain more active without making our brain tumors grow? I don't know. Long story short is that is a really important question. There are a number of studies in my lab and several others working on that important point because that is a concern. I don't have evidence for or against it yet, but that is really important. Now, with respect to activity through nicotine, that's an even harder question. I was really thinking more of stimulants through like psilocybin, right, and certain mushroom therapies, and which are being applied in a number of different depression and psychiatric anxiety type disorders. And the natural transition was to want to apply those treatments or those therapies in trials for patients with brain tumors. But there is that caveat of, are we stimulating too much to the point that it could actually be harmful to tumor growth? We'll have to do trials to understand that.
Certainly. Thank you. Yeah, a fascinating question and one that remains open to me as well. We have another question about a patient that underwent a right temporal lobectomy, had removal of the right temporal lobe, and is wondering about how this will affect the quality of life of the patient, and wondering also if the function of the right temporal lobe is going to be superseded now by the function of the left temporal lobe, the left amygdala and hippocampus.
Yeah. So the right side of the brain is a really important area. So classically speaking, most of us as neurosurgeons would think that the right side, frontal lobe and temporal lobe, are quiet areas of the brain. It's not really true. Your brain is, our whole brain is there for a reason, right? The question is whether the function is so important that it impacts the quality of your life. Now, the quality of life is really determined by you and how the things that each of us as individuals and how it impacts the things that we do. So a right temporal lobectomy is almost certainly going to give a patient a little bit, at least a small amount of visual field cut. Again, right side of brain would be a left kind of superior visual field cut. If you're a sort of person like me who does some basic hiking and hangs out with family and other things like that for quality time and some running, probably not a big deal. But I have patients who are hobby or commercial pilots and other things like that. And you absolutely could not fly with a right temporal resection because your visual fields are not full. So um, I think it's important as you talk about, right-sided resection and what does that mean for, quality of life. I think it's very individual based on the type of things you do. I would expect that, again, as a right-handed person, the left side of your brain would largely be responsible, left temporal lobe would largely be responsible for language and many of the cognitive aspects of language. But there are a few people, about 1%, that have right hemisphere language. And those rare people could also have quality of life concerns as well. I hope that at least gets a little bit to your question.
Certainly. Yes, yes, yes. We have a comment now thanking you for a wonderful presentation, an amazing example of taking very detailed scientific information and talking through them in a way that was easy to understand. So we acknowledge that comment as well. I have a few other questions that I think might be worth discussing.
Mhm.
Do you have a particular approach in terms of your recommendations for supportive therapies after operations? Oftentimes after a patient undergoes an operation, they get assessed by physical, occupational, and speech therapists, and they make an assessment as to what patients need. And there's an acute offering of therapy. But for patients with long-term deficits, particularly speech deficits, do you find in your practice that ongoing speech therapy is of use, and is that something you recommend?
Yes. Okay. So that's a great question, and I'm trying to think of the most efficient way to answer it. From in my opinion, so first of all, I think more services are always are almost always better. Okay, as a blanket statement.
Yeah,
Um, but you need the right therapy at the right time. So
yeah,
if you have malignant disease, and we know that we need to get you into radiation chemotherapy before your tumor grows back, um, then we don't always have a lot of time to wait. And so sometimes we have to go with a good enough approach, um, meaning maybe cap out physical therapy at 10, 14 days, and you still walk with an AFO, but we can get you home and get you into rehab. At least in our part of the country, inpatient physical therapy or post-acute services are about 3 hours of exercise a day, right? As you know, it's really hard to get through that when you're also actively getting radiation. And so those can be plugged in as an outpatient or plugged in more afterwards. For patients with low-grade disease, you certainly have time to do all of the therapy, physical therapy, occupational therapy, etc. Um, speech pathology. I tend to recommend for patients to have an initial PT and cognitive eval up front, and then following surgery. But oftentimes we delay the next physical therapy and the next speech pathology appointment until they kind of hit a more static level in their speech. Right after many of our treatments, particularly surgery, symptoms fluctuate quite a bit by day, and it's really hard sometimes for a therapist to treat a moving target or give strategies for a moving target. So it can be a little easier once you're more in the stable range in terms of treatments. The last plug I'll put in for these sort of services is that there's a great amount of disparity in different parts of the country and even regionally between what sort of outpatient local services are available for individual patients. I'll tell you, parts of California, it's very hard to find a speech pathologist that's worked with anybody who hasn't had a stroke before. And so, for example, it's not uncommon every month or two, a couple of months, I'll get a call from a patient that says the speech pathologist said they won't see me in whatever part of California that I went home to. They said I have malignant cancer and none of this is helpful. Completely incorrect. But it's in a place where they have lack of knowledge about these sort of services. And so this is where we rely on our ABTA, our patient-facing organizations, to help with local resources. We rely on our tertiary care centers. More and more of this can be done remote and virtual. So yes, getting these services is great. Right patient, right time, right service. And we really need to be careful about what local services look like and reach out if we don't have it available to us in our communities.
We need to be wrapping up. I see here from the organization, but there are two questions that just came in. I'm going to wrap them into one. And the first question is, how long do you have to wait for the brain to compensate, if able, for loss of function? And then the second part of the question is, after 5 years, has the plasticity ended? There's no more compensation to be expected? What are your thoughts on that, Shawn?
Yeah. How long do I have to answer this, man? We could have that talk based on this. Geez, these are good questions. Okay.
Yeah.
We don't know all the answers. I will tell you part for your first question in terms of when do we start to see evidence of organic recovery for healing and compensation? Well, the Furrows Terrapore study that I mentioned that I like so much, that was about, if I remember correctly, 16 to 18 months.
Yeah.
There are other studies that point out to closer to 3 years. But meaning these aren't decades. There may be changes sooner, but I don't know of a study where we longitudinally just like give people functional MRIs and watch their recovery. That doesn't exist as far as I'm concerned. But what we do know, again, is that there's an incredible amount of compensation that happens organically, at least as a cross section. I can say it's roughly, 12, 14, 18 months, somewhere in there. Okay, functional recovery. Have I plateaued at 5 years? So the steep phase of recovery is usually within that, 3 to 6 month range. It plateaus, but still improves over time up to about a year. There are people who have organic recovery past a year. However, I am really excited about some of the work in the return to work cog rehab space by experts like Ashley Logan, Chris Wire-Jamora, and others that have applied cognitive rehabilitation strategies and programs to patients, and over 90% of time are able to, if I use return to work as a metric, able to see improvements in cognitive scores and quality of life scores to the point where they can get people back to work. So there's a difference between this like organic recovery that we measure scientifically and the therapies that we offer for patients, right, to help get them recovery at a later time period. And that's where I say the optimal timing of these strategies is unknown right now. So because it's unknown, I would say that if you are experiencing impairments and you want to seek a specialist, just talk to that specialist and try the treatment, because I don't think there's a time in which we can say we cannot, you might not be able to rehab. Okay.
Thank you so much, Shawn, for that very detailed answer. And thank you so much for all our viewers with very interesting and very on-point questions. It's been a real treat to have you today, and I'm sure that many patients and caregivers have benefited from your knowledge today, and will continue to do so as the program will be posted online. We're going to take a short 4-minute break so you can stand up and stretch your legs, go to the bathroom, get some water, and then we'll resume with our next talk in a few minutes.
Yes, thank you so much. I just wanted to say thank you, Shawn. We really appreciate you being here today with us and sharing your insight and expertise. It's always an honor to work with you. See you in just a few minutes for our next session.